a 59-year-old former smoker with few months of 2 to 3 block intermittent claudication. So he has prior history of ischemic stroke. There was a stroke in the past with no residual weakness 3 years ago. Underwent right carotid endarterectomy following his stroke. He's currently on aspirin 81 milligram daily and being treated with lisinopril and simvastatin so for his hypertension and dyslipidemia. So patient with a history of a stroke and endarterectomy coming to you. Now that patient has intermittent claudication. What would be the appropriate additional medication that you can add to the medical therapy here? B. Okay, well, exactly. So add it with Zorriasateyn. 2.5 milligram twice daily. So let's ask another question about this patient. So, okay, what is the estimated major cardiovascular adverse event relative risk reduction for this patient if he continues to take rivaroxaban twice daily and aspirin for another 2 years? What number you pick? 28%. That's a big number. That's a big number. So just add in 2.5 of rivaroxaban. So what is the relative risk reduction for major limb events? Assuming continuous and regimen. So major limb event, amputation, CLI, acute limb ischemia. Hey, wow. Nobody can believe that. 50%. 50%. We're going to talk about it now. So this is all coming to us. All these adverse events coming to us from atherothrombosis. The term atherothrombosis. So atherothrombosis is thrombosis complication of atherosclerotic disease. So atherosclerosis by itself won't hurt us much. The moment we have atherothrombosis, we're in trouble. That leads to cardiovascular event, MI, stroke, and then we have the bad outcome, in front of us. We have like a, limb loss. So, and then it causes, rapid, perfusion defect, and that everything comes after that. So it usually starts by exaggerated platelet response to atherosclerotic process and endothelial injury. There should be a start point that we start getting atherothrombosis. Either a platelet aggregation or somehow the coagulation cascade, initiated. So you don't want to go through these details because of the time. But in the past, we were always thinking, oh, we have atherothrombosis, we use antiplatelets. This was the concept for many years, for 30, 40 years, past 40 years. We have venous thrombosis or thromboembolism, we use anticoagulation. And that was like a rule of thumb. So, but despite that, we were seeing, residual antithrombotic risk remained high despite antiplatelet therapy. The antiplatelet is not enough. Combination of antiplatelet did not show significant benefit. They added the Plavix to the aspirin and said, there's too much bleeding. So, and then they had only limited use in certain post-revascularization time that they use it for short period of time. But the moment that short period of time passed, when we start seeing, we're getting hitting hard, and then this doesn't work. If works, comes with a bleeding risk. So, look at the pathway. So, this is the atherothrombosis pathway. Both platelet activation and both coagulation cascade activation, they both work together to give you atherothrombosis. And they can interact. And particularly interaction goes with protease activated receptor pathway here, that you see this connection. And then both pathways lead to atherothrombosis. It doesn't make sense that you're only hitting the platelet and you just you can't, sort of stop this from happening. So they were using Coumadin, didn't work. They were using full dose anticoagulation, didn't work. So, I'm sorry, I'll keep going on this wrong bottle. So, and then, but with the rivaroxaban 2.5 milligrams twice daily, it worked. How? That was part of the COMPASS trial. It was a very large trial that, they were focusing on patients with non-complicated coronary artery disease, and they're trying to see if they can reduce their major, cardiovascular event by adding anticoagulation to their antiplatelet. They were trying the rivaroxaban 5 milligrams twice daily, 2.5 milligrams twice daily, and then comparing it with aspirin alone. As part of that trial, about 8,000 patients fit in the Kambiz PAD trial, what the question was all about. They pulled the people with the PAD out of that pool. You know that the atherosclerosis is a multi-vessel disease. So if you have it in one bed, you have a very high chance of having it to the other bed. So I can go back in here. So look at this. Like 60% of the patients, 60% of the patients in the REACH registry, they had a multi-vessel disease, PAD and coronary disease together. So that's how they pulled that out of that pocket, and then they did the Kambiz PAD. So they came with that patient with coronary disease, said whoever has a prior, sort of proven PAD would include in this trial. They came up with, it was like a 558 centers, and then they were just collecting these for 3 years. They ended up with like almost 7,500 patients, and they followed them for close to 2 years. And then looking at major cardiovascular outcome and the major limb outcome, adverse limb outcome, and they were looking at the bleeding too. So what they found was here. So this is the answer to that question, that we had significant reduction of the major cardiovascular event when we used the 2.5 milligram twice daily plus aspirin. So when we're using the 5 milligram rivaroxaban, we ended up with a major bleeding and not much, net benefit out of it. But that's where we see that 28%. You see 5 versus 7% with 72% hazard ratio, 28%, sort of benefit out of it. And the conclusion was low dose rivaroxaban 2.5 milligram plus aspirin 81 milligram. We used it 100 milligram. Used it, reduced the major cardiovascular outcome and limb outcome compared with aspirin alone, with no significant increase of fatal or critical bleedings. So let's look at this slide. This slide, this is a subgroup of those patients. That is 120 patients with actual limb outcome. And then, so actual limb outcome, see that this major limb outcome. So they said when you look back, the one that they were on 2.5 of rivaroxaban twice daily, the rivaroxaban lowered the incidence of the limb event by 43%. 43%. And then total amputation, vascular amputation reduced by 58%, just keeping them on rivaroxaban. So and then here, I think I have one more slide about this group. This is another study that look at the patients that they ended up with some sort of bad limb outcome. See, everything comes to them. So the moment these are the patients that cardiovascular and limb event after peripheral artery vascular. The moment there's some limb event happen to them that they revascularize, everything is going to, the red one is the outcome of the bad cardiovascular outcome. The moment they revascularize, things are going to happen to them. So for example, so this is a patient with a major limb event, and this is a patient without major limb event. You see, the moment that you get that major limb event, you're going to end up with bad cardiovascular outcome anyway. So there's another study that they applied what they found in this controlled trial. It was a very controlled setting that they did the Kambiz trial, and then they said, well, let's apply the Kambiz trial to a real world. They used the REACH registry, which was a registry for 47,000 patients, real patients that they collected prospectively. So they went back and then they started looking back and see what if we use this patient as part of this study. What they found is that in the real world, even it works better. So patients with the polyvascular disease that they have peripheral artery disease, they benefit from these combination therapy. What is the term we use? We put dual pathway anti-thrombotic therapy, where we use the the antiplatelet plus anticoagulation low dose. The data we have is on rivaroxaban 2.5 milligrams twice daily.
Question. So that was, with aspirin. Any benefit with Plavix?
So I think we had that in the Voyager trial, which is a post-revascularization trial. I didn't go through my intention was this case was not to talk. In the Voyager trial, they included patient with the Plavix, and actually it worked. It worked the same thing for post-rev. The data we have on the post-revascularization patients when they did the Voyager trial, which came 3 years later. So they said, okay, well, these are the patients with the stable coronary disease and peripheral artery disease. These are multi-vessel disease, atherosclerotic disease. Let's focus on the PAD patient only, going for revascularization to see how they do. They did the Voyager trial. In Voyager trial, we did use the Plavix as the antiplatelet, and still the result was satisfactory.
Not better than just rivaroxaban and aspirin?
Well, no, it's Plavix plus rivaroxaban.
Oh, okay.
Yes, the data on the control trial is on a Voyager trial, but not on the Kambiz trial.
Sure.
I think I will.
Question back there.
Venous sinus thrombosis and any literature of that?
Transverse sinus thrombosis. So, well, the transverse sinus thrombosis, do you have any specific question about transverse sinus thrombosis, or you want me to give some comment on it? The roll-up?
The roll-up
Anticoagulation. Oh, well, so the venous sinus thrombosis was kind of rarity in the general practice, unless for some neurologists that they come across those venous sinus thromboses. And one of the unusual thrombosis size in human body that usually overlook if you don't put it on your differential diagnosis. And the treatment of venous sinus thrombosis and the concept of venous sinus thrombosis is stuff like, getting to know after this J&J vaccine, sort of couple of cases that reported people is getting more attentive to it. And I actually saw a couple of patients with them post-vaccine with the post-vaccination. But for treatment of transverse sinus thrombosis, we don't have a data on direct oral anticoagulant. That's the first message. So we don't use it, especially in acute phase. So there are young people that may not be like, they're not accepting the Coumadin as a long-term commitment, but I would just hesitate to use anything but Coumadin in the acute phase when we have them. And definitely we need to look for possible thrombophilia when we see the patient with the sinus thrombosis coming to us. You always think about, okay, what caused the sinus thrombosis? And then you have to do the thrombophilia workup and then make sure that there is no contributing factor to it. And the acute phase management usually is better to be done in the tertiary center, especially that you have to anticoagulate this patient when they're just having a bleeding because of increased venous pressure. So sometimes they come as the congestive bleeding of the brain, and then when they come, usually they tag them as the patients with the intracranial hemorrhage, which is due to severe increased pressure of the sinuses leading to the bleeding. And the anticoagulation needs to be done in a very controlled setting under care of a neurologist and the vascular specialist or a hematologist with expertise in that field.